In this video, let us look at dislocation of shoulder. It is the most common joint to dislocate, the shoulder joint, also called as the glenohumeral joint, isn't it? It is the most common joint to displace. So here you have the humerus, here you have the scapula, and here you have the clavicle, right? So this joint is a ball and socket variety of joint, isn't it? Synovial joint. This is the most common joint to dislocate. So here they have shown you anterior dislocation of the shoulder joint. So let's get started with this dislocation of shoulder. So you can see this shoulder joint needs a lot of things to keep it stable. Okay. The factors that provide stability to the shoulder joint are these rotator cuff muscles. Okay. Then you have the coracoacromial arch, the long head of biceps tendon, the glenoid labrum. All these are providing stability to the shoulder joint. So the rotator cuff muscles, you can see here from the posterior view, this is the supraspinatus, infraspinatus. Then you have the teres minor shown here. This is the posterior view of the right shoulder joint. And the anterior view, you can see the subscapularis, right? So these are the four muscles of the rotator cuff, musculotendinous cuff. So these are all provide stability to the shoulder joint. And there are a lot of ligaments also here, guys. Look at this, the you have to understand the parts first of all, right? See, here you have the glenoid. Okay, this is the glenoid cavity of the scapula. Here you have the acromion process and the corocoid process. Acromion is attached to the clavicle. So you have the acromioclavicular joint you have, right? So basically, all these ligaments that you see here, where is gleno? This is glenohumeral ligament, coracohumeral ligament, transverse humeral ligament. So there are so many ligaments also around this. What are the arteries supplying it? You have the circumflex humeral arteries. You have the scapular arteries, suprascapular and the subscapular artery. So remember circumflex humeral arteries. Okay, this is a part of the axillary artery. Everything a part of axillary artery. Coming to nerve, you have the axillary nerve, suprascapular nerve, and musculocutaneous nerve. Remember axillary artery, axillary nerve. That much will help a lot. Axillary artery, axillary nerve. Okay. What you should understand is the glenoid cavity, right, of the scapula, that is very small than the head of the humerus. So that is why what happens, you have something extra here, which is the labrum, which kind of compensates or makes up for the small glenoid cavity so that the head of the humerus can sit here. So basically you can understand this shoulder anatomy you have understood now. You'll have to draw those diagrams in the exam, guys. It's very simple. Just draw something like this. Let's just draw it, okay? This will become your humerus. Okay, 1 second. This can become your humerus, and here you can draw the glenoid cavity of the scapula, okay? And here you can draw the glenoid labrum. So this can be your humerus and this can be your scapula. And here you can show the acromioclavicular joint. Okay. So people, there is something called as shoulder instability. Now look at this terminology, shoulder instability. The head of the humerus is not stable in the glenoid. Okay, in the glenoid, this head of humerus is not stable. So there can be some minor instability, that is a loose shoulder, or something like a frank instability. Anyways, now look at this. In this minor instability, there will be pain in the shoulder due to stretching of the capsule. The head moves out in some direction, but there is no actual dislocation. Now coming to frank instability, there is actual subluxation, they are saying, partial movement, abnormal movement of the head of the humerus, partial movement which gets spontaneously reduced. By itself it can get fixed, okay, or it can go into a dislocation also, looks like. And this instability can be in any direction or multi-direction. Now let us get back to shoulder dislocation, people. So shoulder dislocation, basically let us look at the mechanism why this shoulder is dislocated. So basically, if you fall on outstretched hand, standard things that you will write, right? There is a direct force pushing the humerus head out of the glenoid cavity, okay? So this will push the head out of the glenoid cavity. If it has to be a posterior dislocation, what will happen? You will have to punch it from front. A direct blow from the front will push it backwards, so it becomes posterior dislocation. But what did you understand so far? Anterior dislocation is very, very common than posterior dislocation, okay? For that, the reasons you can search. Okay, meanwhile, just understand this. If it is posterior dislocation, it can be mostly because of a shock or an epileptic convulsion, okay? Posterior can also be because of direct blow from front. So, dislocation of shoulder can be what and all? Can you say the names? You already know two types, anterior, posterior. Anterior humerus comes out of the glenoid cavity and lies anteriorly. That's what we know. It is very common. And in that some types are there. Then you have the posterior dislocation. The humerus comes to lie posteriorly, that is behind the glenoid. Ahead of the glenoid, anterior dislocation. Behind the glenoid, posterior dislocation. And there's one more, guys. It is previously called as inferior dislocation, or inferior dislocation is not the right word. It's more like a subluxation, luxatio erecta. This is where it is subglenoid. So it is not completely dislocated. That's why they seem to be calling it as more like a subluxation. So anterior is ahead of the glenoid, posterior is behind the glenoid. Okay. Now in anterior there are four types again. So these are the four types of anterior dislocation. Let us look at the right shoulder joint. That will be easy for us to understand. So here you have the normal. Here it is preglenoid, subcorocoid, infraclavicular. So just remember the subcorocoid is most common. Okay. Subcorocoid is the most common. That it is below the corocoid, below the corocoid. Okay. And then you have below the clavicular. That is not common. Which is the commonest? Subcorocoid. Okay. These diagram, see, so nicely they have shown here that subcorocoid is most common. So they have put it here. Subcorocoid is below the corocoid process. Very good. And then here subclavicular is below the clavicle. And this has gone so much inside the ribs itself. This is intrathoracic. All these are anterior. What are all these? Anterior dislocation of shoulder. Okay. Look at this. We are looking at the head of the humerus, but not the remaining part looks like. Here you have the posterior capsule. Here you have the anterior. This is the glenoid cavity looks like. And here on top you have the subscapularis tendon. Subscapularis. And this is the periosteum. What bone is this? Glenoid. Glenoid means scapula. Okay. Now, what are the pathological changes? What can you see? Pathoanatomy of anterior dislocation of shoulder. You will see Bankarts lesion. What is Bankarts lesion? Basically, there is stripping of the glenoid labrum. So, glenoid labrum stripping. Okay. Then what is this? Hill-Sachs lesion. Depression of the humeral head. And then this one is eburnated rim of the glenoid. So you have to remember only two things. Bankart and Hill-Sachs. Bankart is where there is stripping of the glenoid labrum along with the periosteum from the antero-inferior surface of the glenoid and the scapular neck. And then you have the Hill-Sachs lesion. Guys, this is becoming a little technical, isn't it? So much too difficult to understand. Hill-Sachs lesion is depression in the humeral head in its posterolateral quadrant. And there can be rounding off of the anterior glenoid rim in chronic cases or repeated cases, okay? There is fracture of the greater tuberosity. There can be associated injuries, like there can be fracture of the greater tuberosity of what? Of the humerus, right? And there can be rotator cuff tear, those muscles whichever we told you, right? That tear also can happen. So how is the patient going to present? He is going to present with his shoulder abducted and elbow supported with opposite hand. There will be pain and there will be inability to move the shoulder. He cannot move the shoulder, okay? And you can see that on examination, you can see the round contour of the shoulder joint is lost. It has become flat, okay? And below the clavicle, there could be fullness. Below the clavicle, there could be fullness. Why? Who is sitting there? Because the head of the humerus can be sitting there, okay? Below the clavicle, there can be fullness. Now, what will you do for this guy? You can do Duga's test. Duga's test. And you can do one more test. That is Hamilton ruler test. Hamilton ruler test. Okay. See, this is how they present. After this only, you will do this Duga's and Hamilton ruler test for diagnosis. Okay. So, what is this Duga's test? So, this is Duga's test. What you're seeing here, there will be inability. They can't do this actually. Whatever she's done in the photo, they can't do. Inability to touch the opposite shoulder. Okay. They will have inability to touch the opposite shoulder. Then coming to Hamilton ruler test, what is this? See, because this deltoid, whatever they're showing here, which muscle are they showing here? Because of the flattening of the shoulder, you know what will happen? If you place a ruler on the lateral side of the arm, you can see here, this will touch the acromion process. See, the ruler is touching the acromion process. Why? Because there is flattening of the shoulder, isn't it? The acromion process is touching the ruler. Okay, then you can take an X-ray, right? Very easily you can take an X-ray and you can confirm. Where is the X-ray? Here you can see. They've just shown an X-ray here of shoulder dislocation, anterior dislocation of shoulder. So this is yet another diagnosis. Posterior dislocation, when does it occur? Come on, try to recollect. Epilepsy and electric shock, right? And for this you will need, for distinguishing whether it's anterior, posterior, you may need a lateral view, okay, of X-ray. So even in X-ray you can miss the posterior, they are saying. So you will have to check there is loss of external rotation, etc. Or you can do a CT. So treatment of shoulder dislocation, guys, so you'll have to reduce the dislocation, right? Reduction you should do. Then you have to immobilize, you put splint, cast, all those. And then after you remove these bandage after a few weeks, then you can allow for shoulder exercise, right? So in reduction there are two ways. They're talking about Kocher's maneuver. And then you have this Hippocrates maneuver. Let us look at this Kocher's maneuver first. In this, the steps are like this. TEAI, is it? Yeah. Traction with elbow flexed. Okay. Elbow is flexed. Then you're putting traction along the axis of the humerus. Second one is external rotation. In external rotation, what are you doing? That's it. External rotation. The arm is rotated externally. That's it. Then 3. 3 is adduction. With this externally rotated arm, you will adduct. Adduct means you are bringing towards the body, right? Externally rotated arm is adducted by carrying the elbow across the body towards the midline. Then fourth one, internal rotation, that is I. TEAI. I is internal rotation. The arm is rotated internally. The arm is rotated internally so that the hand falls across the opposite shoulder. This should fix the dislocation. Wow. But this you will not do like this, okay? He's not going to be awake like this. It should be under general anesthesia or sedation. This guy should not be awake. They are shown awake in this photo. Okay. Hippocrates maneuver. Let's look at this one now. Look at this Hippocrates one. The surgeon applies a firm and steady pull on the semi-abducted arm. He keeps his foot in the axilla against the chest wall. The head of the humerus is levered back into position using the foot as a fulcrum. This sounds a little quackish actually, but that is Hippocrates maneuver. The fracture, okay, of the greater tuberosity, if it is there, then anyways it will get automatically corrected by all this reduction. They are saying that, okay. So then you will immobilize, cast plaster of Paris, etc. for a few weeks, months, then bandage remove, exercise the shoulder, okay. Now we will look at the complications of shoulder dislocation. So there can be injury to the axillary nerve, right? Where is the axillary nerve? Look at the axillary nerve here. Okay, that's the artery. Where's the axillary nerve? Okay, here. It's going around the humerus neck of it. This is the axillary nerve. So there can be damage to this. If there is damage to this, there will be paralysis of the deltoid muscle, okay? So they'll have an anesthetic patch here, small area of anesthesia. So it's called some badge where they put their military badges, right? That area is anesthetized, okay? That is the lateral aspect of the shoulder. How you can also know is you can ask him to abduct, but he can't abduct, by the way, because he has shoulder dislocation. But whenever he is trying, there is absence of contraction of the deltoid. Deltoid is paralyzed. Paralysis of the deltoid muscle. Because of what? Injury to the axillary nerve. Nerve itself injured now. Okay. That is one of the complications of shoulder dislocation. Then, late complications we have to look at. Recurrence. Why the shoulder joint dislocation will keep recurring? If they have Marfans syndrome, they'll have an unstable joint. So instability will lead to recurrence. Inadequate healing. So the first time the shoulder dislocated, it didn't heal completely. Epileptic, there will be a lot of posterior, we saw, right? Posterior dislocations. Now, how do you prevent recurrence? You can do some Putty Platt operation, you can do some Bankarts operation, Bristow's operation, Arthroscopic Bankart repair. Let's look at this Putty Platt. Okay, this is Putty Platt. What they are doing is the supscapularis muscle is there, right? That one they are double breasting. So they are cutting it and then one on top of the other each other. They are folding it and tightening it, kind of thing. This will tighten it, right? So basically, what they are doing, double breasting of the subscapularis tendon in order to prevent external rotation and abduction. So they cannot externally rotate and abduct, is it? So anyways, there will be no shoulder dislocation. What is Bankart's operation? See, Bankart lesion, you know, right? That is that glenoid labrum stripping, right? So basically here, what they will do, you have seen that Bankart lesion, remember? Bankart lesion. This one, Bankart lesion. The stripping of the glenoid labrum, something you studied, remember? So what they will do in Bankart repair, Bankart operation, the glenoid labrum and capsule are reattached to the front of the glenoid rim. So this is very technically demanding, but it has become simple with a device called as anchors. So what are they talking about here? This glenoid labrum. So they are using something like anchor, they said, right? And they are able to work on this glenoid labrum. Okay. So glenoid labrum, Bankart's operation is done. Now let's go to Bristow's operation. Here, they are working on the bone, the corocoid process. It's osteotomized. Look at this image here. So this is the corocoid bone to which some tendon is attached, etc. They're taking a part of that corocoid process, they're removing it, that is osteotomized, and they're attaching it, fixed it to the lower half of the anterior margin of the glenoid. So it will give dynamic anterior support to the head of the humerus. Okay, this kind of looks like they're removing a part of the bone and fixing it here. Okay, this is Bristow's operation, bone, they're working on the bone. Okay. Then coming to last one here, arthroscopic Bankart repair. For that textbook itself has given the image. Let's look at that. Arthroscopy means you'll use a camera and enter with a small port, isn't it? So they are entering here, you can see, and this is the Bankart lesion. The problem is with the glenoid labrum, right? Then they are putting some arthroscopic repair with anchors. So same word anchors they are using here, but they are going with arthroscopy, right? They are going with a small hole. They'll enter with a camera like that, and they will show. So they're showing the scar of the arthroscopic repair is so minimal, right? This is an open repair which scar is so huge, okay? So in this video, we wanted to look at shoulder dislocation. It is the commonest joint in the human body to dislocate. You have anterior dislocation, which is more common. So basically, shoulder joint has instability because the size of the head of the humerus is very large compared to the glenoid cavity. So you have the labrum which supports it, a lot of ligaments, etc., which support the shoulder joint. So shoulder joint can be unstable. The instability can be like a minor instability, etc. So there are types of instability. Then when people fall on their outstretched hand, etc., they can have the shoulder dislocation. Anterior dislocation, guys, fall on outstretched hand, direct blow, etc. So subcorocoid is the most common one. It is below the coracoid, and subclavicular below the clavicle, and then you have the intrathoracic, which is almost gone into the thorax, right? Then posterior dislocation can happen because of direct blow from the front. So it will go backwards, the posterior dislocation. It can also happen in epilepsy and shock, okay? Basically, electric shock. So posterior dislocation is not that common, and to know whether it's posterior, you will have to probably take a lateral X-ray. Inferior subluxation is more like a subluxation, not a dislocation, okay? Then coming to the anterior one, what and all are the pathoanatomy? Pathoanatomy means what exactly will you see is wrong. You will see that there can be a Bankart lesion, that is the glenoid labrum is stripped, okay, stripping of glenoid labrum can be there. Then you can have this Hill-Sachs lesion where you can see the depression in the humerus head of the humerus. Then what else are they talking about? Rounding off of the anterior glenoid rim, okay. Then all this can be, shoulder dislocation can be associated with fracture of the greater tuberosity, rotator cuff tear, etc. Because rotator cuff muscles are a very huge support to the shoulder joint, okay. How will you diagnose? You will see that the shoulder, round contour of the shoulder is lost, it would have become flat. This person will come with a shoulder abducted, it's away abducted, and elbow is supported by opposite hand. This pain and inability to move the shoulder. Then there will be fullness just below the clavicle, okay, because of the head of the humerus, right? So then what else will you check? You will ask Duga's test. You will ask the person to do like this, but they can't touch the opposite shoulder. So that will become Duga's test. In Hamilton ruler test, you will keep the ruler. In normal people, you cannot touch the acromion process. In this, you can touch the acromion process because of the contour of this shoulder joint is lost, isn't it? Then obviously you will do an X-ray and you will see the dislocation. You can do a lateral one if you want to know if it's anterior, posterior, etc. Then coming to the treatment, you will have to reduce under general anesthesia sedation. You have the Kocher's maneuver, that is T, that is the traction, external rotation, abduction and internal rotation. Traction is like you keep the elbow flexed and you will protract, and then you have external rotation. Then internal, abduction. Abduction, you are bringing it back to the towards the body. Then you have internal rotation, and he will touch the opposite shoulder. This you have to do in sedation and general anesthesia, remember. Then you have immobilize, then you have the Hippocrates maneuver also. If you want, you can try. This is yet another maneuver to do the reduction. So here they are using the foot and providing traction. And if there is a fracture of the greater tuberosity, that also will get fixed, they are saying. Then you will cast and immobilize, etc. Then after some weeks, months, you can remove the bandage, and shoulder you can exercise. That will be rehabilitation, right? So what are the complications of shoulder dislocation? There can be injury to axillary nerve, because of which there will be paralysis to the deltoid muscle. There can be anesthetic patch here, wherever the military people put their badge there. Okay, and how to check this injury to axillary nerve? If you ask them to adduct, they cannot adduct anyways, and you will see that there is no contraction of the deltoid muscle, because axillary nerve is not there to supply, right? The axillary nerve has been injured. Late complications, recurrence, that's all they are talking about. Basically, if it is a Marfans syndrome, they can have instability, they can have recurrence, inadequate healing if it has happened, or if they are epileptic, we told you there can be posterior dislocations in epilepsy and electric shock. How can you prevent recurrence? You can do the Putty Platt operation, where you are working on the subscapularis muscle, double breasting of the subscapularis. Then Bankarts operation, glenoid labrum you are working on, right? And then coming to bristow's operation, you are working on the corocoid process, that is the osteotomy. You are doing this corocoid process, you are cutting it part of it and you are fixing it lower below, so that anteriorly you can give some support to the joint, that is bristow's operation. Then you have the arthroscopic Bankart repair. Arthroscopic Bankart repair, where you are going through the scope and you are giving the Bankart lesion you are fixing. So this is very cosmetically appealing. Okay. So that's it for now in shoulder dislocation. Bye bye.